lentiform
Go
type,
ahead.
lentiform type hematoma collection, most probably extradural hematoma, and effacement of the equilateral ventricles and midline shift of the brain parenchyma.
First of all, tell me what type of scan is this?
Non-contrast CT.
Non-contrast CT. And do you see any particular thing inside the hematoma as well?
Swirl signs.
Viral sign.
What is swirl sign?
It is
Bleeding present.
ongoing bleeding in the that ongoing bleeding. Represent ongoing bleeding.
Well, it tells you there might be ongoing bleeding. What do you see? How would you describe what you see?
Heterogeneous area.
Heterogeneous foci within the hematoma. And then you can see bruising outside the skull as well. You can see the bruises outside the skull. Oh. So this would be extradural hematoma station. So why don't we go to the notes? So extradural hematoma, it's a neurosurgical emergency. You have to act quickly. Why does extradural hematoma happen? Where does it happen? Usually,
Anywhere between the dura and the
where does it commonly happen? After trauma.
Commonly Tyrion area because of
the
due to
middle meningeal.
anterior branch of the middle medial artery laceration.
Why does it happen around the Tyrion area?
It's the thinnest part of the skull, and that's why it's gaze. Most likely.
It's not the thinnest part of the skull. It's rather
It's the most
the
exposed,
weakest part of the skull.
weakest part. Yeah.
Not
It's also where
necessarily thinnest, but yes, of course, the squamous part of the temporal bone is probably the thinnest part of the skull, but the weakest part of the skull is around the Tyrion, and there is anterior branch of the middle meningeal artery passes just beneath it. Any blow to that area will result in extradural hematoma. So the imaging, as we've seen briefly, CT head without contrast is the first line in the trauma cases. And the signs, what you can see are 1, biconvex hematoma, as we've seen it, midline shift, effacements of the lateral ventricles, and the swirl sign is heterogeneous focal attenuation within the extradural hematoma. That may indicate extravasation of the ongoing bleeding. So let's go to the radiopia. Again, this is my favorite go-to site for the radiology as well. So you can even scroll it in. Scroll in. So what we're going to see is, you can see this is the extradural hematoma, and then there's a swirl sign inside it, as you can see. And you can see the effacement of the lateral ventricles. The right side, the lateral ventricles are quite compressed. Effacements meaning they are compressed and then they're gone. And then you can see the midline shift is curved as well. So the midline should be in the midline, but it's a little bit curved. So this is pushing it to the side. So midline shift, effacement of the lateral ventricles, and biconvex hematoma. So this is extradural hematoma. Next, GCS. So we keep talking about the GCS. What are the components of the GCS?
Eye opening, verbal and motor component.
Verbal, motor, and verbal, eye, and the motor. So how do we score the GCS? What's the minimum?
3.
3. Maximum is
15.
15, obviously. GCS, you don't necessarily need to know these, but they haven't really asked GCS in details, but you should know how to assess it. It's usually 4, 5, and 6. Our response. Normally, if the GCS is 9, for example, sometimes it may not be enough. It's better to, the best way to describe the GCS is through E2, V3, M4, for example, but nobody does that in reality, unfortunately. So GCS, please do have a look at it yet, but we don't necessarily need to know in details. But next, how are we going to manage extradural hematoma? What's the management?
A, B, C, D, E, according to the ATLS protocol. And after that, you can raise head to 30 degrees.
Why do we raise the head to 30 degrees?
It will increase the venous return and decrease the ICP. You can give mannitol and furosemide. You can intubate and hyperventilate the patient, induce hypothermia, induce a barbiturate coma. It's usually a surgical emergency, so the first thing would be to get him to surgery.
Anything else?
Um,
What type of surgery?
Antiepileptics, craniotomy plus extradural hematoma evacuation, or a burr decompression if it's an emergency.
Right. So, for example, we can do the steroids as well. Right. So steroids are very good at reducing the mass effect.
Dissecting source.
Right. So let's go through by one.
But steroids are contraindicated now for trauma, for neurotrauma.
Especially with the open traumas and stuff, yes. So steroids may not be, well, steroids has become lately controversial topic, but that has long been a part of the protocol. I believe we still give the steroids, but I can double check later on. Right. So that's why I haven't really removed the steroids yet.
Okay.
A2 assessment as per idealist protocol, raise at 30 degrees. Why do we do that?
For reduce
Increase
venous pooling, venous.
To drain the venous blood better, because if you remember, 75% of the blood is in the venous system. Only 25% is in the arterial system. So if you've got higher pressure inside the cranium, what you want to do is drain the veins. Next, mannitol furosemide. This is to reduce the intravascular volume as well. And next, especially in the elderly who is taking warfarin, for example, you have to reverse the anticoagulants. How do you reverse warfarin?
By giving
vitamin K.
And
you need to reverse it right now.
No, you can give
complex concentrate.
You give
fresh frozen plasma.
Concentrate. Or if it's not available,
fresh frozen plasma.
Next step is a fresh frozen plasma. So we'll talk about the reversal of the warfarins in different cases. Vitamin K, we don't usually use that in emergency situations because it's going to take at least quite a few hours. Right. Next, intubation and hyperventilation. This is to do two things. One is prevent hypoxic, ischemic, and encephalopathy. As we said, the neurons are quite sensitive because after a few minutes, they start to die. So you have to continuously provide oxygen to the neurons. And next is the control of carbon dioxide. So why do we need to control the carbon dioxide?
Cerebral vasodilatation, and it will increase the vascular compartment, and it will increase eventually intracranial pressure. That's why we need to control that.
That's correct. It's a very potent vasodilator. And every time there is an excessive amount of carbon dioxide, it's going to cause a vasodilatation. What we don't want is vasodilatation, more blood coming and increasing the intracranial pressure. So we're not going to do that. And then steroids, again, slightly controversial, but usually give it to reduce the mass effect. So we use that in the tumor cases as well, for example. To control the seizures. Hypothermia. Why do we do the hypothermia?
Slows down all the biochemical
metabolic demand reduce.
It reduces the metabolic demand. For example, if you cool down the brain to a certain hypothermia level, it reduces the oxygen concentration by 75%. For example, if you go down to 18 degrees Celsius, that's a very deep hypothermia. We don't do that anymore, but we still use it in some surgery. Right. At this point, what I usually say is deep hypothermic circulatory arrest. I'm not sure if you've heard of it, but there is a procedure where we switch off the circulation in cardiac surgery, obviously, where we switch off the circulation and I suppose the bypass machine as well. Do you know what surgery would that be? I believe that is the only procedure in the world where you switch off the circulation altogether.
Aortic root replacement.
Say again?
Aortic root replacement.
When you're attaching the heart-lung machine to
you
the
switch
circuit.
off the heart-lung machine as well.
Oh.
Bypass?
Definitely not. Do you think we routinely switch off everything in the bypass? No. So what the bypass, cardiopulmonary bypass do is we put the cannulas in, one into the aorta and then two in the right atrium. And then we connect the right atrial line to the machine where they get all the blood supply. Ultimately, all the blood come back to the right atrium, right? So we drain that blood in the machine, and then we collect it in a reservoir, clean it, oxygenate it, and then push it back into the cannula, into the aorta. And then we clamp it, and then we stop the heart. So the machine takes over both the heart and the lungs. But sometimes we have to switch off the machine as well. And the only procedure, as I'm aware, is the aortic arch replacement. If you're going to replace the arch of the aorta, at least to a certain extent, we have to switch off everything. Everything, meaning including the cardiopulmonary bypass machine as well. And to protect during that one, we do something called deep hypothermic circulatory arrest. So we cool down the patient to 20, 22, 24. Some people would like to cool down the patient to 18 degrees Celsius as well, and then switch off everything. For 30 minutes, you do not need to worry anything. If the patient's in deep hypothermia, up to 30 minutes, it's safe, including the brain. So stroke rates are minimal and no cognitive dysfunction happens up to 30 minutes. It's very, very fascinating, because if we do that in a normothermic, the brain would be probably dead. The person might be already dead, because it's up to 30 minutes. It's not just a few minutes. As you said, after a few minutes, the neurons start to die. Well, so that's why if you're going to certify death of the patient, what is one of the things that you have to make sure?
Temperature.
Temperature.
Body must be at room temperature, meaning normothermic. If the patient is not normothermic, the patient is not dead. Well, so there have been a case report, lots of them, in fact. One of the very famous case report is a doctor went to skiing in Switzerland or Norway, I can't really remember, and then she got buried under the snow, and then she had a cardiac arrest. So after 3 days, I think 1 or 2 days or 3 days, I can't really remember, but after a few days, they brought her back to the emergency department, resuscitated her, and she lived without any residual deficit. And she wrote a book about it, by the way. Well, so that's very, very fascinating body about it. So one of my consultants usually jokes during the not jokes as in, but ask about a philosophical question. Is the patient alive or dead if we are doing the hypothermic circulatory arrest? So how do you define the patient's alive?
Brain stem reflex
function.
Well, you won't have brain function during the anesthesia anyway. So if you give anesthesia, is the patient already dead?
It's sort of a suspended animation. I would say it's between death and alive.
So the line's there is no right or wrong answer, by the way. The line is very blurry in cardiac surgery, right? And the highest limit that we push is the deep hypothermic circulatory arrest, where there is no brain function, no heart function, no lung function, no kidney function, no functions at all. And we bring the patients eventually back from death as well. That's why we call the cardiopulmonary bypass machine the hands of God, right? Because cardiopulmonary bypass machine, what you would think is just takes over the heart and the lungs. No, it can do pretty much everything. It can do the kidney's job as well. For example, it can filter out the toxins, and you can change the temperature. We cool the patient using cardiopulmonary bypass machine. We rewarm the patient using the cardiopulmonary bypass machine as well. Cleans the blood, oxygenate the blood, pumps the blood out. So cardiopulmonary bypass machine, it's a miracle that we've got it. And
out of curiosity, can I ask a question? Just out of curiosity, how long does it take for you to induce that hypothermia?
Depends on which degree that you want to do. So we usually take about an hour to cool down the patient to 24 degrees Celsius. We can cool it much quicker, but the problem is if you cool it quite quickly, that will cause metabolic derangements, and the patients will even have more trouble than that. So we do it very slowly in a controlled manner. So it takes about 1 hour to cool down, 1 hour to bring it back up.
Thank you.
Right, no problem. Great, come back to the station. So the last step would be neurosurgery, obviously compressive craniotomy or burr hole evacuation if it's an emergency. So before we move on, there are indications for intubation. These are the general indications for intubation. So tell me, what are the indications for intubation, intubating the patient?
GCS less than 8.
8.
Why
It
do we
could-
intubate the patient if the GCS is, so you said GCS less than 8. So if the GCS is 8, are you going to intubate the patient?
Yes.
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 8 is
Less than
inclusive.
9. Less than 9.
All right, so whatever you remember, make sure 8 is inclusive. So GCS
Yes.
8 or less, we're going to intubate the patient. Why?
Because of the
Protect the
patient
airway.
can't maintain
airway.
airway.
They cannot maintain the airway patent. Right? Patency of the airway will be compromised sooner or later. That's why we intubate patients. Anything else?
For
Respiratory
What's
surgery,
less-
one reason we intubate in an
Surgery.
urgent situation?
for surgery,
Respiratory arrest, respirate less than
Respiratory distress most of the time, right? Surgery is the most common elective reason. Of course, electively, if we're going to intubate, that's because of the surgery. We don't go around and intubate patients, right? So indications for intubation is mainly acute respiratory failure. That's probably the most common reason in the acute settings, or inadequate oxygenation ventilation, for example. That is in COPD patients. Eventually, they will go to the respiratory failure if you don't intervene. Airway protection in depressed mental status, GCS 8 or less, 8 is inclusive because they cannot maintain the airway. Hyperventilation in ICP patients like this one to control the carbon dioxide as well as to prevent hypoxic injury. Managing bleeding or corpus secretions, again, sometimes trauma patients, there's a lot of bleeding inside the airway and you need to suck them out. Right? And then surgery is the most common elective reason for us to intubate the patients. What are the indications for surgery?
collection more than 30 cc, focal neurological sign.
GCS less than 9
GCS
needs to
less
go
than,
midline
GCS
shift
less
more than
9,
5
meaning
millimeters.
GCS 8 or less, and anisocoria, meaning
Meaning
Unequal
Trans-
size
calculation.
pupils.
unequal pupil. So
pupil abnormalities, and lastly,
midline
deterioration
shift.
progressive
neurology. So even if the other things doesn't apply, patient's getting eventually worse and worse and worse and worse, we're not going to wait until the last minute. We will probably intervene earlier than that. So indications for surgery in general: 1, focal neurological deficits that is directly contributed to the extradural hematoma, GCS less than 9 and anisocoria. Large hematomas, how large is large? It's usually either 30 cubic centimeters or 30 mil that you can measure on the CT scan, or progressive deterioration of the intracranial pressure and neurology. So let's talk about the intracranial pressure. What's a normal intracranial pressure?
7 to
7
15
to 50
mmHg.
millimeter mercury.
Millimeter of mercury, 7 to 15 millimeter of mercury. And what is the perfusion pressure?
So
Cerebral perfusion pressure.
mean arterial pressure minus ICP.
Very good. That's a difference between the mean arterial pressure and the intracranial pressure.
Pressure.
So mean arterial pressure, how do you calculate the mean arterial pressure, by the way?
Systolic minus diastolic.
Pulse pressure by
Say it again.
Systolic minus
Systolic
1/3
minus
pressure.
1/3 of diastolic pressure.
Diastolic plus 1/3 of
Plus
pulse.
1.
1/3.
Plus 1/3 of pulses.
So there are a few different formulas to calculate it, but ultimately the easiest way is diastolic pressure plus 1/3 of the difference between the diastolic and the systolic pressure. That is called the pulse pressure. What does the pulse pressure tells you, by the way? What if there is a very narrow pulse pressure? Systolic and diastolics are pretty much the same, almost the same. What does it tell you?
Reduced perfusion because of due to pressure gradients.
There will be reduced perfusion, but very narrow pulse pressure. What does it tell you? Cardiogenic shock. What? Keep that in mind. Very low stroke volume will cause the pressure, systolic, diastolic pressure difference very minimal. That tells you the patients might be in cardiogenic shock. So keep that in mind. We'll talk about this later. So diastolic pressure plus 1/3 of the pulse pressure is the MAP, or mean arterial pressure. Mean arterial pressure is the best indicator of the blood pressure overall. You compared to the systolic or the diastolic pressure alone. Right? So many of the time we will use mean arterial pressure. So the difference between the mean arterial pressure and the intracranial pressure is the perfusion pressure. And if the intracranial pressure rises, it will causes less gradient and the blood, as we keep saying, like all the gases and the fluids, flows from higher pressure to lower pressure. And if you eradicate that pressure gradient, the blood will stop flowing and that will cause a lot of problems, right? So how can we measure the intracranial pressure?
How do we measure it? We have invasive and non-invasive.
Non-invasive.
So for non-invasive, we have translinear Dopplers. We have your membrane,
You measure with a
tympanic membrane
transcranial
displacement. Sorry, you measure the velocity of the blood flow. The tympanic membrane displacement, and you have the intraocular measurements,
pressure,
measurement
intraocular
for the optic
sonography.
nerve diameter. And invasive, you have the intraventricular probe or intraparenchymal probe,
Interparenchymal probe,
subarachnoid probe.
subarachnoid.
Right, so there are a few ways to measure it, both invasively and non-invasively. Normal ICP, so we set 70-15 mm of mercury. Perfusion pressure is the difference between the MAP and the ICP. So the measurement. So non-invasive way, you mentioned about the tympanic membrane. So the problem with the tympanic membrane, what's
Not
behind
accurate
the membrane?
Accurate, yeah. It's
because
connected
of the eustachian tube,
this taken you connected throat.
What's behind the tympanic membrane?
middle ear cavity.
Middle ear.
Middle ear cavity. Middle ear cavity is not a true intracranial cavity because it's connected to the pharynx via the eustachian tube. If the pressure is so high, eustachian tube is going to open up and then equalizes. That's a protective mechanism. That is to prevent the rupture of the tympanic membrane due to very high pressures, for example, changes in the altitude or any change or any pathology inside the middle ear cavity increasing. So that's why tympanic pressure is not usually indicative of the intracranial pressure. So transcranial Doppler, we can put through the ultrasound probe. It's an ultrasound ultimately, and then measure mostly middle cranial, middle cerebral artery. We'll measure the velocity, and then we can estimate what's the pressure inside it as well. Next is the ocular sonography. So the transcranial Doppler, it's a Doppler, and the problem is it's got a very narrow window where you can see the middle cerebral artery, and often the examiner will find it difficult to find that window. So what we have developed later on, the latest one is something called robotic transcranial Doppler. So the patient wears kind of like a helmet, and the robot itself kind of like evaluates the flow. So that is the most accurate and the most useful, eradicating the need for a person to do Doppler manually. So it's a very new thing, and we in our center we started doing that about a year or two ago. But anyway, so we're the first in the world to start doing this one. So it's a very, very interesting and very expensive equipment as well, transcranial Doppler, the robotic transcranial Doppler. Next is the
Is it accurate?
Say again?
Is it accurate enough for neurosurgery?
I'm not sure for the neurosurgery, but it's fairly accurate to tell you the flow, and it tells you the pressure. Again, it's an estimation of the pressure, but in cardiac surgery, what we want is the flow. So we get that quite accurately. Great. So the next is the ocular sonography. What do we measure?
Diameter of the optic nerve.
Diameter of the optic nerve sheath. So if the patient is intubated and quite sick, one of the things that you can do is measure the optic nerve sheath using the ultrasound on the eye, ocular sonography, and measure the optic nerve sheath. And there have been studies consistently pointing out the optic nerve sheath diameter corresponds to the intracranial pressure as well.
Yeah.
And then intraocular pressure, you can measure it from the outside as well, right? Sorry. Next, the invasive ones are the gold standards, obviously. One is intraventricular monitoring catheter. intraparenchymal subacromial epidural probes. You can put these in invasively and measure more accurately. Of these, what's the difference between intraventricular and the rest of the probes?
You can take out the CSF with intraventricular.
You can drain the CSF, which is therapeutic for the increased intracranial pressure as well. Right. So why are pupils dilated with the increase in the intracranial pressure?
Oh, it is due to loss of parasympathetic activity of the oculomotor nerve, which is Eddington nucleus, and loss of parasympathetic supply, and then dilate the pupil because of the sympathetic sympathetic part is overcome.
What does the parasympathetic system do to the pupils?
Constricts them.
Constricts the pupil.
It constricts them. Right. So imagine if you're going to have a very big meal. After a big meal, you feel sleepy and then you want to sleep. So parasympathetic system is constricting the pupil. But if you're going to get into fight or flight response, you need to dilate the pupils to see everything, and then either you're fighting or
Running away.
Right. So sympathetic system will dilate the pupils, parasympathetic will constrict the pupil. Both sympathetic and parasympathetic systems are carried by
The third nerve, oculomotor nerve.
oculomotor nerve. So why would parasympathetic system be affected and not sympathetic system?
The
Parasympathetic
sympathetic
fibers
system
go
nature-
peripherally of the nerve.
It's thought that parasympathetic fibers travel around the periphery of the nerve, and compression initially will compress on the peripheries of the nerve, leading to parasympathetic loss. As a result, an opposed sympathetic action will lead to dilated pupils. And it's usually by the transtentorial hernia, right, compressing on the oculomotor nerve and affecting the parasympathetic supply, and failure to constrict the pupils, and an opposed action of the sympathetic system will lead to the dilated pupils. Great. What is the lucid interval?
Temporary improvement in the patient conditions after head injury, after which the patient will undergo rapid deterioration.
We all know what a lucid interval is, but if the examiner asks you, make sure you know how to describe it as well. It's a temporary improvement in the patient condition after traumatic brain injury before the patient continues to deteriorate. What is Monro-Kelly doctrine?
So it's a theory that describes the brain as a rigid box, and inside that box is three things: the brain parenchyma, the CSF, and the blood. So basically it tries to define what will happen when you increase the pressure in there. So the
So
first
what
thing to go
happens?
is the CSF, second thing, the blood will compensate. And the third, obviously the brain parenchyma will get compressed.
Right. So Monro-Kelly doctrine, it's described the skull as a rigid box and with three components in it. Obviously, the majority, 80%, is the brain parenchyma inside it. The remaining 10% is the CSF and the 10% of blood eventually. If there's an increase in the inside the cranium, what is least required of out of these three?
Yes.
CSF.
CSF, obviously. So the start to reduce the CSF first, followed by blood, and if it's not enough, it will reduce itself, which is the herniation of the brain. Up to about 25 millimeter mercury, the brain can handle the auto-regulate these mechanisms as a protective measure. But beyond that one, even a slight increase will cause the herniation of the brain totally. Skull is a rigid box with three components: brain about 80%, blood 10%, CSF 10%. Increase in one component will lead to a decrease in, must lead to a decrease in another component. Right. Now the patient's found to have very high blood pressure and bradycardia. Why would that be?
The Cushing's reflex.
So very high blood pressure usually accompanied by the tachycardia, not bradycardia, which is a quite weird things happening. So Cushing's triad or the Cushing's reflex, what are the three things that happens?
Hypertension, bradycardia,
Hypertension,
irregular
bradycardia, irregular respiration.
Why does hypertension occur?
to compensate for the cerebral perfusion pressure, to improve the CPP or when the ICP is raised.
Very good. When the ICP is raised and the map is relatively more or less the same, So as we said, we are eradicating the difference between the two. And as we said, blood flows from high pressure to low pressure. Now the brain senses that blood's not coming. So what it tries to do is raise the blood pressure to create more gradient. As a result, hypertension results. And that is via the sympathetic system, obviously firing the beta and causing, overall sympathetic system is activities increase. So beta activity will lead to the increase in the heart rate as well as the contractility, and alpha activities will cause the vasoconstrictions that ultimately raises the blood pressure. So how does bradycardia happens?
Blood pressure
By treating
increasement and
baroreceptors.
baroreceptor stimulate, and then eventually parasympathetic system activate and then leads to bradycardia.
Once there is persistent hypertension, then baroreceptors will get activated. Where are the baroreceptors?
Carotid body.
Body and aortic arch.
And the aortic arch as well, right? There are baroreceptors at the carotid, not the carotid body.
Yes, sorry.
Carotid sinus.
Carotid sinus.
Producer.
The way I remember is a sinus, so you can stretch it, and stretching will sense the pressure. So carotid sinus and the aortic arch, the baroreceptors will get activated. And in turn, these are strong inputs for the parasympathetic system. And the parasympathetic system tries to fires the vagus nerve, and a lot of firing of vagus nerves will slow down the heart rate, significantly leading to bradycardia. And unfortunately, part of that mechanism, firing of vagus nerves on the stomach, what does it do?
Loss of Cushing ulcers.
It causes a hypersecretion of the acid, increased secretion of the acid, leading to disruption of the protective
Mucous membrane,
stomach, leading to the ulcers. And these ulcers are called
Cushing ulcers.
ulcers as well. And lastly, irregular breathing. So the pressure, direct pressure on the respiratory centers in the medulla oblongata will lead to irregular breathing. Right. So that's something called Cushing's triad or Cushing's reflex. And again, it's important to understand these principles behind it. Hypertension, so cerebral ischemia, leading to sympathetic activation, and alpha receptors, peripheral vasoconstriction, as well as the beta one as well. The bradycardia, persistent hypertension will activate the baroreceptors, parasympathetic activation, and that will lead to the decrease in the heart rate, as well as going to lead to the Cushing's ulcers as well. Regular breathing, hypertension, increase ICP will causes the pressure onto the respiratory centers and causes irregular breathing as well. So lastly, what is Canadian CT hat rule? Or in other words, what are the indications to do a CT scan in a trauma patient?
It's divided to less than 1 hour and it's within 1 hour and within 8 hours. And
so let's start with the 1 hour group. So the first group, you must do the CT scan within 1 hour. So tell me.
GCS less than 13 and GCS less than 15 after initial assessment within 2 hours, and skull fracture, focal neurological sign, and post-traumatic seizure, and vomiting more than 2 episodes after head injury.
And an isocoria.
Vomiting more than one. And isocoria usually is not included, but rather with the focal, it will go with the focal neurological deficits category for that. The next group would be less than, you must do the CT scan within 8 hours. So what would that group be?
Age more than 65, use of anticoagulants, retrograde amnesia more than 30 minutes, and loss of consciousness with any...
It's not a complete answer. There is a big thing missing.
So it's either post-traumatic amnesia or loss of consciousness plus elderly or coagulopathy or serious mechanical injury.
They must contain 2 conditions. The first one is either amnesia or loss of consciousness, and the second condition is any of the following. So this is loss of consciousness and amnesia must be present plus any of the following. Then we do this. So you have to perform the CT at less than 1 hour. If the GCS is less than 13 on the initial assessment, meaning the GCS is down, or GCS comes down, still not shifting 2 hours afterwards. Focal neurological deficit contributed directly to the trauma. open or depressed skull fractures, obviously, post-traumatic seizure, vomiting more than once, meaning if the patient's vomit once, you still not need to do the CT, but more than once, you have to do the CT within 1 hour. The second group, loss of consciousness or amnesia plus any of the following. So the elderly, older than 65, coagulopathy, high impact injury like road traffic accidents, falling from the stairs, for example, and retrograde amnesia more than 30 minutes.